Welcome back to the Deep Dive. Today we are shifting gears. Usually we take a broad topic and explore it for the curious mind, but today we have a very specific mission. I need you to imagine a specific setting.
Okay.
The air conditioning is humming, there's a slight smell of old paper and nervous sweat. We are going into exam mode.
It's a feeling every doctor knows well. Specifically, we are stepping into the shoes of a postgraduate student preparing for the MD anesthesiology exams.
Yes.
We're looking at the curriculum often seen in places like Gujarat University, but honestly, this is universal. This is the viva voce.
The dreaded Viva. And I am playing the role of that stressed-out final-year resident advocate. Miller's anesthesia open on one side, Morgan and Mikhail on the other, and a stack of scribbled notes. My palms are sweaty.
And sitting across from me is you.
And sitting across from me is you, the senior faculty, the examiner, with the spectacles perched on the end of your nose waiting for me to slip up.
I'll try to be a benevolent examiner today. But you're right, the pressure is real. And today's topic is a classic. It's a piece of equipment that you will almost certainly find sitting on the table in the regional anesthesia station.
The nerve locator.
The nerve locator, or the peripheral nerve stimulator.
It looks like such a simple little box, a couple of wires, a dial, a digital screen.
Yeah.
But I feel like this device is a trap. It's deceptively simple. If I just say it finds nerves, I'm going to fail, aren't I?
You won't fail, but you won't get the honors marks either. The nerve locator is a bridge between physics and clinical practice. To the examiner, it represents your understanding of physiology, anatomy, and safety.
Oh, it's not a magic wand.
If you treat it like a magic wand, we have a problem. If you treat it like a precision instrument governed by Coulomb's law, you're in business.
Okay, let's unpack this. I want to structure this deep dive exactly how I would structure a long question or a comprehensive 20-mark answer in the theory paper.
A good plan.
We need to cover the basic concept, the physics, which terrifies me, by the way, the equipment, the technique, and of course the safety traps.
That is a solid plan. So let's start. You walk into the station. I point to the gray box on the table and I ask, Doctor, what is this? How do you begin?
Okay, I take a deep breath. And I don't just say nerve stimulator. I need to be precise, I'd say. This is a peripheral nerve stimulator, also known as a nerve locator. It is a device used in regional anesthesia to identify peripheral nerves by applying a specifically controlled electrical current to the tissues via an insulated needle.
Good start. Very good. But immediately I'm going to stop you. I'm going to point to another device on the table. The Trainophore monitor we use for muscle relaxants. They look similar. Are they the same thing?
Okay. The first trap, no, absolutely not.
Explain.
The neuromuscular monitor, or the TOF watch, is for assessing the degree of paralysis at the neuromuscular junction. It typically uses surface electrodes. The nerve locator is for finding the nerve in the first place using a needle.
So one monitors the block.
And the other helps create the block. They are fundamentally different tools for different jobs.
Exactly. Never confuse them. Now, give me some context. Why do we even care about this box? We have ultrasound machines that look like they belong on a spaceship now. Why are we still learning about this, this older technology?
Because it was the gold standard of the pre-ultrasound era. Before this, we had the paresthesia technique, which, from what I've read, sounds barbaric.
Barbaric is a strong word, but it was certainly subjective.
You just poke around with a needle until the patient screamed or felt a lightning bolt down their arm, right?
Well, not exactly screamed. But you relied on the patient being awake and able to report that sensation. Tell me when you feel a shock. That's not great if you have a confused patient or a sedated one or a child.
So the nerve locator changed the game because it made the process objective.
Exactly. Objective is the key word. It's a physiologic method.
Right. I don't need the patient to talk to me. I just need their muscles to talk to me by twitching. And even today, with ultrasound, we still use it. We call it dual guidance. It's like wearing a belt and suspenders. The ultrasound helps me see the anatomy.
The structure.
But the nerve locator confirms, yes, that circle on the screen is definitely the nerve because the finger is twitching. It provides that functional confirmation.
Precisely. It answers the question, is this structure I'm looking at actually the nerve I want to block? Now let's get into the part that makes most residents sweat. The principle. The physics. Miller goes heavy on this. What is the fundamental law that governs this entire process?
It's Coulomb's law. E equals K times Q over R squared.
Okay, you've memorized the formula. But if I'm the examiner, I'm going to take off my glasses, lean forward, and ask, what does that actually mean in English, doctor?
Okay, In simple terms, it means that the current I need to stimulate a nerve is inversely proportional to the square of the distance from that nerve. So basically, if my needle tip is far away from the nerve, I need a loud shout, a high current, to get a reaction. If I'm standing right next to the nerve, a tiny whisper, a very low current, is enough to make it fire.
That's a good analogy. Current intensity is our proxy for distance. We are using electricity to measure millimeters, but it's not just about distance, it's about time.
Okay.
Tell me about the strength duration curve. Tell me about Rheobase and Chronaxie.
Right. These two words haunt my dreams.
Right.
Rheobase and Chronaxie. Let me try to explain it simply. Rheobase it's the floor. It's the minimum current intensity required to stimulate a nerve if you could let that current run for an infinite amount of time.
Good. So imagine a graph. The curve flattens out. Below that line, no matter how long you shock the nerve for, it simply will not fire. That intensity is the Rheobase. Now, what is Chronaxie?
Chronaxie is a measure of time. It's the minimum duration of the pulse that's required to stimulate the nerve, but specifically when the current is set to exactly twice the Rheobase.
Correct. But here's the so what question. The examiner will always ask, why do we care? Why isn't this just, trivia for physiologists?
Because different nerve fibers have different Chronaxie values, and this is the key to patient comfort.
Go on.
We have motor fibers, the A-alpha fibers, and we have pain and sensory fibers, the A-delta and C fibers.
But what's the difference?
The motor fibers are big, they're myelinated, they're fast, they have a short Chronaxie, around 0.05 to 0.1 milliseconds. They're very easily excited. The pain fibers are smaller, they're slower, they have a much longer Chronaxie, they need a longer pulse to get going.
So if I set my machine to a very short pulse duration,
then I'm hitting the sweet spot for the motor nerve. If I set the pulse duration to, say, 0.1 milliseconds or 100 microseconds, I can make the muscle twitch before the pain fibers have even woken up.
And what if you set it for longer, say 1.0 milliseconds?
Then I'm going to stimulate everything. The patient will get a muscle twitch, sure, but they'll also feel a burning, stinging pain. It's not selective anymore.
Exactly. This is differential stimulation. By keeping the pulse width short, we selectively talk to the motor component and largely ignore the sensory component. It's elegant. It allows us to locate the nerve without hurting the patient.
So that's why the standard setting on the machine is 0.1 milliseconds.
That is precisely why. And if you change that setting in an exam without a very, very specific reason, you will fail that station.
Got it. Okay, so physics summary. Coulomb's law relates current to distance. Chronaxie allows us to separate motor twitch from pain.
Perfect. Now let's pick up the device. Part B, equipment. In a table viva, the examiner hands you the equipment. Identify the components for me.
Okay, I'm holding the box. First, the generator. It's battery operated. This is a safety feature, right? Okay. To prevent electrocution from mains power.
Correct. And what kind of generator is it?
It's a constant current generator.
Why constant current? Why not constant voltage? This is a key point.
Because the resistance in the human body changes. As I push the needle through skin, then fat, then fascia, then muscle, the impedance fluctuates.
And Ohm's law tells us?
Ohm's law says voltage equals current times resistance. If R is changing and the voltage was constant, then my current would be fluctuating all over the place. We don't want that. We want the current to be exactly what the dial says it is.
So the machine automatically adjusts the voltage.
Exactly, to keep the current stable and constant regardless of tissue resistance.
Excellent explanation. Next component, the needle.
This is a huge Viva topic. The insulated needle. A standard hypodermic needle is, just metal. It's conductive along the whole shaft. If I use that, the current leaks out everywhere.
It's like a soaker hose.
Yeah, exactly. The current weeps out along the whole length. If I get a twitch with an uninsulated needle, I have no idea if the nerve is at the tip or if the shaft is touching the nerve 2 centimeters higher up. It's imprecise.
And the insulated needle, how is it different?
It's coated in Teflon or some other insulator. The only conductive part is the tiny bevel at the very tip. It's like putting a high-pressure nozzle on a fire hose. It forces all the current, all the electron flow, to exit right at that pinpoint tip.
And what does that do, electrically speaking?
It creates a very high current density at the tip, and it ensures that if I get a twitch, the nerve is definitely right next to that tip. It gives you precise localization.
Correct. Current density is the key concept here. You want a concentrated field, not a diffuse one. Now, connect the cables. You have a red cable and a black cable. Which one goes where?
Negative needle. That's the mantra you have to remember. The black cable, the cathode, goes to the needle.
And the red?
The red cable, the anode, goes to the skin electrode, the grounding pad.
Why? What happens if you get it wrong and swap them?
Oh, this is a classic trap.
Yeah.
If I make the needle positive, the anode, I'm fighting physiology.
How so?
Cathodal,
Yeah.
the negative current, it pulls positive ions towards it, which makes the nerve membrane potential less negative and causes depolarization. It makes it fire. Anodal, the positive current, does the opposite. It causes hyperpolarization. It makes it harder for the nerve to fire.
So what would you see clinically if you reverse the polarity?
I might still get a twitch, but I'd need way, way more current, maybe 3 or 4 times as much.
And the danger of that is?
The danger is that I might think I'm far away from the nerve because I need 2.0 milliamps to get a twitch, but actually, I'm sitting right on top of it, just using the wrong polarity. I could damage it.
Exactly. An Edo block, a classic trap. Always check your connections. Negative needle. Now, let's look at the screen. What are the standard settings you were going to dial in before you even touch the patient?
Okay, so before I start, I set. Current, I start high, usually 1.0 milliamp to 1.5 milliamps. I need to cast a wide net to find the nerve initially.
Makes sense.
Pulse duration, as we said, 0.1 milliseconds or 100 microseconds. Short and snappy to spare the pain fibers.
Good.
And frequency, usually 2 hertz, so 2 twitches per second.
Why 2 hertz? Why not 1 hertz or even 5?
Well, 5 hertz would be too fast, almost titanic, hard to see a single twitch. 1 hertz is fine, but 2 hertz gives me faster feedback. If I'm moving the needle, a whole second is a long time between pulses. I could glide right past a nerve in that 1 second of silence.
So 2 hertz is a good compromise.
Yeah, it keeps me updated on my position more rapidly.
Good. So you're set up, your machine is ready. Now we move to part C. The technique. You've prepped the skin, you've positioned the patient appropriately. Walk me through the algorithm. How do you actually find the nerve?
It's a game of seek and dial down. That's how I think of it.
Okay, explain that.
Step 1. I enter the anatomical area with my current set at, say, 1.5 milliamps.
Right.
Step 2, I watch for the motor response. Let's say I'm doing an axillary block. I'm looking for a twitch in the fingers.
Okay.
Step 3, the moment I see the desired twitch, I stop moving the needle. This is important. You stop.
And then what?
Now, I need to refine the position. So reduce the current. I turn the dial down to 1.0 milliamp.
And what happens?
One of 2 things. If the twitch is still there, great, I'm close. If the twitch disappears, it means my whisper is too quiet for this distance. I'm still too far away.
So what do you do if it disappears?
I advance the needle, slowly, just millimeters at a time, until that twitch comes back at the lower current setting. And then I repeat the cycle. Turn down the current, see if the twitch fades. If it does, advance the needle slightly.
Stepwise approach.
Yes. Turn down current, twitch fades, advance needle, twitch returns. Over and over.
And what is the goal? What is the end point you're aiming for?
The holy grail, the sweet spot, is a distinct, clear twitch between 0.3 milliamps and 0.5 milliamps.
Okay.
If I have a nice, strong twitch at 0.4 milliamps, I am confident that my needle tip is in the sweet spot. I am perineural right next to the nerve sheath.
Why stop there? If closer is better, why not aim for a twitch at 0.1 milliamp?
But no, that's the danger zone. This is crucial for the exam. Absolutely crucial.
Tell me why.
If I get a twitch at a current of less than 0.2 milliamps, I'm too close. In fact, studies suggest I might be intraneural, meaning the needle tip has punctured the nerve sheath and is sitting inside the nerve fascicles themselves. If I inject my local anesthetic there, I'll cause pressure damage, a compression injury, potentially permanent neuropathy.
So what is the rule?
The rule is, if the twitch is present at 0.2 milliamps or less, do not inject. You must withdraw the needle slightly until the twitch disappears at that 0.2 setting, but then returns when you dial it back up to 0.3 or 0.4.
Perfect. That is the safety margin. 0.3 to 0.5 is the window for injection. Now, you're at 0.4 milliamps. You're happy. Is there one last check you can do before you inject the full volume?
Yes, the Raj test.
What is that?
I inject a small test dose, just 1 or 2 ml of local anesthetic or even saline, and as I inject, the twitch should immediately stop.
And why does it stop? What's the physics behind that?
There are 2 main reasons, I think.
Go on.
1, the fluid I inject physically pushes the nerve away from the needle tip, so the distance in Coulomb's equation has increased.
Right.
And 2, the fluid itself is conductive. It disperses the current density away from the nerve. It sort of shorts the circuit.
Very good. And what if the twitch doesn't stop? What if it keeps pounding away as you inject?
That's another red flag. It could mean a few things, but the most concerning is that you might be intravascular, and the local is being washed away instantly. Or, potentially, you could be intraneural. The bottom line is, a persistent twitch during injection means stop and reassess.
Excellent. That is the complete algorithm. Start high at 1.5, your goal is 0.5, you avoid 0.2, and you use the Raj test to confirm. Now let's move to Part D, clinical applications. In the exam, they will ask you about specific blocks. Doctor, what twitch are you looking for? Let's do the interscaling block for shoulder surgery.
Okay, interscaling. We are targeting the roots and trunks of the brachial plexus in the neck. I want to see a twitch in the deltoid muscle causing shoulder abduction or the biceps causing arm flexion.
And what do you not want to see?
I don't want to see the trapezius twitching. That means I'm stimulating the accessory nerve, I'm too posterior. And I definitely don't want the patient to start hiccuping.
A hiccup means what?
It means I'm stimulating the phrenic nerve. My needle is too anterior. The phrenic nerve runs right on top of the anterior scalene muscle. If I see the diaphragm jumping, I need to pull back and redirect more posteriorly.
Very good. What about the supraclavicular block, the spinal of the arm?
Right. Here we are at the level of the trunks and divisions, much more compact. A biceps twitch is okay, but ideally we want distal stimulation. We want the hand or fingers to talk to us.
So flexion or extension?
Exactly, flexion or extension of the fingers or wrist. If I can get the hand to twitch at 0.5 milliamps, I know that block will be solid for the entire arm.
Good. Now for a classic trick question, the femoral nerve block.
Okay. For a femoral block, I'm aiming for the nerve just below the inguinal ligament. The desired response, the one you're looking for, is the patellar snap.
Describe that.
The quadriceps muscle contracts powerfully, and the kneecap, the patella, literally jerks or snaps upward toward the head.
And what is the trap here?
The trap is the Sartorius twitch. The Sartorius muscle runs right over the top of the femoral nerve. If I'm too superficial, my needle will stimulate the Sartorius first.
What does that look like?
You'll see a twitch in the medial thigh, sort of
Okay.
wobble, but the patella won't snap. If I accept that and inject, the block will be patchy or will fail completely. I need to go deeper, pass through the fascia iliaca to get that true quadriceps twitch.
Very good. That distinction between the Sartorius wobble and the patellar snap is worth a lot of marks. What about the sciatic nerve? Let's say a popliteal approach, behind the knee.
So in the popliteal fossa, the sciatic nerve is usually split into the tibial and the common peroneal nerves, even if they're still in the common sheath.
Right.
So if I find the tibial component, I'll see plantar flexion of the foot. The foot pushes down like pressing a gas pedal. And usually some inversion too.
And the other component?
If I find the common peroneal component, I'll see dorsiflexion, where the foot pulls up, and eversion.
Is one better than the other?
Both are acceptable. And getting either one at 0.5 milliamps usually results in a complete block since they're so close together there. The tibial component is often considered a slightly more reliable target because it's larger and more central in the sheath.
Correct. Now let's zoom out. Part E, safety and comparison. You mentioned ultrasound earlier. If an examiner asks you, compare and contrast the nerve locator with ultrasound, how do you structure that answer?
I'd set it up as a comparison table in my head, point by point.
Okay, give me the points.
First, visualization. Ultrasound gives you direct visualization of the anatomy, the nerve, the vessels, the pleura. The PNS is a blind technique, relying on a surrogate marker, the twitch.
Good. Next.
Second, the endpoint. The endpoint for ultrasound is watching the local anesthetic spread around the nerve, getting that donut sign. For the PNS, the endpoint is the disappearance of the twitch after a test injection, the Raj test.
Volume of local anesthetic.
With ultrasound, we can often use lower volumes because we can see exactly where the drug is going. With PNS, we sometimes use slightly higher volumes to ensure the nerve gets soaked, since we can't see the spread.
Any advantages of PNS over ultrasound?
Well, USG can be difficult in very deep structures or in obese patients where the image quality is poor. The PNS is relatively unaffected by depth as long as your needle is long enough.
And what about safety?
They both have risks. Ultrasound is generally better at reducing the risk of intravascular injection because we can see the blood vessels and avoid them. But the PNS, if used correctly, is excellent for reducing the risk of intraneural injection because of that 0.2 milliamp rule.
So if they ask you in the exam, which is better, what do you say?
The diplomatic and I think the correct answer is that ultrasound is generally considered the gold standard now for success and speed. However, the safest approach is arguably dual guidance.
Combining them.
Yes, using the ultrasound to place the needle near the nerve and then using the PNS to confirm, yes, this is the nerve, and importantly, warning, you are getting too close.
A very practical answer. You also have to remember that ultrasound machines break, or they're not available in every setting. The nerve locator is robust, it's cheaper, and it's always there.
A reliable backup.
A very reliable backup. Now, Part F exam integration. We are in the final minutes of the Viva. I'm going to throw some classic traps at you.
Okay, I'm ready.
Trap 1. I hand you a cable from the cupboard. It looks like a standard ECG cable. I ask, can I use this cable to connect the needle to the TOF watch monitor instead of the proper nerve locator?
The answer is a hard NO, an emphatic no.
Why not?
For two reasons. First, the connectors probably won't even fit properly. But more importantly, physiologically, it's incredibly dangerous.
Explain the danger.
The TOF monitor, the neuromuscular monitor, is designed to stimulate through skin electrodes, so it puts out very high currents, up to 60 or even 80 milliamps. The nerve locator puts out tiny currents, from 0.1 to maybe 5.0 milliamps.
So if you hooked up the needle...
If I hooked a needle directly to a TOF monitor and fired 60 milliamps directly onto a nerve, I'm essentially electrocuting that nerve. It would cause massive depolarization and potentially irreversible damage. You never, ever mix the devices.
Good. Trap 2. You're doing a block. You've set the current to 2.0 milliamps, no twitch. You go to 3.0 milliamps, still no twitch. You are tempted to turn it all the way up to 5.0 milliamps. What do?
I resist the urge to just crank up the current.
Why?
Because if I'm not getting a twitch at 2.0 milliamps, the problem is much more likely to be with my setup, not the patient. Something is wrong.
So you stop and troubleshoot. What's on your checklist?
First, I check the circuit. Is the anode, the red sticky pad, actually attached to the patient, commonly falls off? Second, is the battery in the stimulator dead? Third, is the cable broken internally?
What else? A big one.
All right. Is the patient paralyzed? Did someone in the operating theater already give a dose of muscle relaxant? If the patient is chemically paralyzed, the nerve locator is a useless paperweight. It relies on muscle contraction to work.
What's the last thing on the list?
I'd consider patient factors. Does the patient have severe diabetic neuropathy, for example? Nerves with advanced neuropathy may not conduct electricity well. Only after I've checked all of those things would I consider repositioning the needle. Just cranking it to 5 milliamps will cause direct muscle stimulation and pain without finding the nerve.
Excellent troubleshooting. Final trap. Trap 3. The examiner asks you to draw a diagram. For a 20-mark question, the diagram is worth 5 marks alone. What do you draw to explain the core principle?
I draw the strength duration curve.
Describe it for me.
Okay, the y-axis is current intensity in milliamps. The x-axis is pulse duration in milliseconds. I then draw a hyperbolic curve. It starts high on the left for short durations and then drops down and flattens out to the right as duration increases.
And what do you label on it?
I label the horizontal line that the curve flattens out towards as the Rheobase. Then I find the Rheobase value on the y-axis. I go up to twice that value, find where that intersects the curve, and drop a line down to the x-axis. I label that point on the x-axis as the Chronaxie.
And for the bonus points?
For the bonus points, I draw a second, similar curve, but shifted to the right of the first one. I label the left curve A-alpha motor fibers and the right curve deltac pain fibers.
And what does that demonstrate?
It visually demonstrates why a short pulse width, like our standard 0.1 milliseconds, intersects the low Chronaxie motor curve, but completely misses the higher Chronaxie pain curve. It's the picture that explains differential stimulation.
If you draw that clearly and label it correctly, you have passed the station. So let's wrap this up. Give me the examiner's checklist, the summary you'd write at the end of your 20-mark answer, the take-home points.
Okay, here are the golden rules of the nerve locator.
1.
Definition. It's a device for objective nerve localization using controlled electrical stimulation.
2.
Principle. It's governed by Coulomb's law, which relates current to distance, and Chronaxie, which allows for differential stimulation of motor over sensory nerves.
3.
Equipment. An insulated needle is mandatory for precision because it creates high current density at the tip.
4. Polarity.
Polarity. Always a negative needle. The cathode. The black lead goes to the metal. Settings. Start high at 1.0 to 1.5 milliamps. Use a short pulse duration of 0.1 milliseconds and a frequency of 2 Hz.
6. Technique.
Seek the twitch, then dial down the current while refining needle position.
7.
The goal. A distinct twitch between 0.3 and 0.5 milliamps.
8. The most important safety rule.
Safety limit. Never inject if a twitch is present at less than 0.2 milliamps because of the high risk of intraneural injection.
9.
Confirmation. Use the Raj test. The twitch should disappear on injection of a test dose.
And 10. The modern context.
Application. It's an essential tool for safety, especially when used for dual guidance with ultrasound, and it's a critical skill when ultrasound is not available.
You nailed it. That is a concise, safe, and scientifically sound answer. One final piece of advice for the exam. Confidence. When you say 0.5 milliamps, say it like you believe it. Don't ask me, is it 0.5? Tell me, the endpoint is between 0.3 and 0.5 milliamps. The nerve locator is about precision. Your answer should be just as precise.
I feel a lot better. It's moved from a scary black box to a logical instrument. Just need to remember, negative needle, 0.5 is good, 0.2 is bad, and don't electrocute the patient with the TOF watch.
Sounds like you're ready for the Viva. Go practice drawing that curve.
Will do. To all our listeners preparing for exams, good luck, keep your currents low and your confidence high. Thanks for diving in with us.
Goodbye.